Hello, welcome to Adventist Healthcare and Youth Podcast. I'm Nimit.
I'm Shanna.
And we're excited to have our new expert today. We have Dr. Bobby Ghosh, who is an interventional cardiologist at Adventist Healthcare through Cardiac Associates. And he's also the director of cardiac research at White Oak Medical Center. So welcome, Dr. Ghosh.
Thank you.
Thank you for coming back.
So as we're getting started, I think many people are looking for healthcare providers, and at times they're looking for a cardiac provider. So when should they start looking for a cardiologist, and what should they look for in a cardiac team?
They should look for a cardiac team that has me on it.
Oh, I like that.
No, I'm just kidding. Well, it's a good question. I guess, there's various ways to choose your team, your doctors, and so on. I think from a cardiology perspective, my thought is, one, you want someone who is going to spend some time to listen to you and to listen to what your concerns are, but also bring forward what they think you should be worried about or thinking about. And then in cardiology, as many people know, there are a lot of kind of subspecialties, and so a lot of groups have members of various subspecialties within their group, and so it's nice, I think, generally, if you go to a cardiology doctor that has an electrophysiologist as another partner and a structural heart specialist as another partner, or all the different subspecialties available, then it's great. If those things are needed, you can be able to see somebody else.
Okay.
Yeah, and navigate the healthcare system, which is already so complex.
So complicated anyways.
Right.
So if you have a heart condition, either heart disease or, something else going on with your heart, you may need to see more than one type of cardiologist.
You may, or maybe you specifically need one specialist. I would say the majority of people generally would need to just see a general cardiologist or someone at least who's doing general cardiology. But in certain situations, so interventional cardiology, which is what I do, is putting in stents and balloon angioplasty and some other procedures like that, as well as some structural cardiology, which is like replacing, aortic valves with a procedure called transcatheter aortic valve replacement. And then there's electrophysiology, which is the electrical side of things. And there people may require a pacemaker, for instance. That would be the most common thing, or management of heart rhythm abnormalities like atrial fibrillation. And then there's advanced heart failure. So, that obviously, as it sounds like, it's something that you would go through the management through a general cardiologist, and at the point where you would need more advanced heart failure management, and even talking about heart transplants and things, that's an entire specialty on its own. And then there are some other kind of newer, smaller groups of specialties, even cardio-oncology, which is kind of a mix between cancer issues and heart issues, and preventative cardiology. I wouldn't call that one small. Actually, that's a little bit newer in a sense, but it's kind of a specialist in thinking about prevention for not necessarily younger, but basically people who don't have a known active heart issue.
I think it's great because preventing something and changing your lifestyle a little bit may go a long ways, and having that dedicated person who's an expert at it is usually beneficial.
Yeah.
So you're an interventional cardiologist, which means if someone is having chest pain and they end up at the hospital, they might see you. Is that right?
Yeah, certainly, the initial process and workup would be typically by an emergency room doctor or an urgent care doctor to kind of look and see if you're having evidence of, chest pain, of course, is taken very seriously, but it can
have to be evaluated.
Come from non-cardiac causes. But once that's kind of, heading towards the direction of, well, hey, this may be a heart artery blockage, a coronary blockage, that's when they would call someone like myself to basically take a look with a procedure called an angiogram, and then, if needed, then open up such a blockage with a balloon and a stent, typically.
So what are some of the symptoms someone should look for if they think they might be having a heart attack? What are the symptoms to watch for?
So chest pain is definitely the first one, the most common one, but it's certainly not by any means the only potential symptom. Sometimes people will feel a little bit more like shortness of breath, sometimes a little sweaty. Sometimes the pain can be in the chest, but it can also radiate towards the arm, especially the left arm, or the jaw or the back even, and sometimes even abdominal sort of pain or nausea associated with it too.
Can women experience different symptoms than men?
Yeah, I mean, I would say on average, probably chest pain is still the most common, but women, for some reason, are more likely to experience some of the less typical symptoms, which is why sometimes it's missed by the patient and maybe even physicians initially.
I've heard lately mini heart attack, small heart attack, major heart attack. What are the differences?
Yeah, that's a great question. I mean, I think sometimes these are colloquial terms, if you will, and sometimes they get passed around and they don't exactly correlate directly to a medical description. But I think what it kind of boils down to is plaque builds up in the arteries over time. That's a slow and continuous process, hopefully a process that we should try to stop. But if and when one day that plaque could break off or rupture, and in that area, then a blood clot starts to form, essentially, because the body starts reacting to this broken plaque that's kind of hanging in the artery, and the wall underneath that plaque kind of triggers a blood clot to form. And that blood clot basically can potentially close off the artery completely. Now, when it closes off the artery completely, 100%, and there's no blood flow getting through, it causes a change on our EKG that we call it a STEMI, or ST elevation myocardial infarction. That's the long term for it. But STEMI basically is the quote unquote big heart attack. And then if it's an incomplete process of completely occluding the artery, which happens a lot of the time, maybe there's that clot and it's kind of like 90%, 95%, there's a little bit of blood flow getting through, then the EKG typically doesn't show that change, what the 100% blockage does. And usually the blood test, there's another blood test that people are probably getting very familiar with nowadays because it's checked every time someone has chest pain in the emergency room, and that's called troponin. And that blood test may still be a little bit elevated because it's starting to show some lack of blood flow, but not that 100% lack of blood flow. And so that maybe is what a lot of times is considered a minor heart attack.
A minor. Okay. Thank you for that explanation. That's helpful. Then, to take it one step further, what is the difference between a heart attack and a stroke? Because it's your arteries, your veins. You may have heart disease if you have a stroke too. So what are the differences?
Right. Well, a stroke essentially is a blockage of a brain artery, while a heart attack is a blockage of a heart artery or the coronary arteries. The underlying buildup of plaque process, we call it atherosclerosis, is basically the same type of buildup of plaque on the walls of the arteries, and inflammation and cholesterol kind of all coming together to create these plaques that build up over time. Now, strokes, they're not always caused by the same exact process. There are some other things that can cause a stroke, one of the most common of which is atrial fibrillation, which is the irregular heart rhythm where clots can actually form in the heart and then exit the heart and go to the brain. And there are other types of strokes as well.
Okay. Thank you for that.
So it sounds like there's some similarities between the two as well. Maybe the risk factors may be similar, not the same, obviously, but be similar for a stroke or heart disease or heart attack.
Yeah, no, they are. I think especially for that atherosclerosis process, which is the plaque, it's essentially the same process happening in two different areas of arteries. And by the way, if it's happening there in the heart or in the brain or both, it's probably also happening in kidney arteries, in leg arteries. And so, all the activity that we can do to try to prevent that is helpful for essentially every artery in the body.
Okay. So don't ignore signs or symptoms. Know your risk factors.
Absolutely. So you mentioned what happens, during a heart attack or some of the signs of heart attack. What happens after the heart attack? Like what happens after you've done the procedure, and what are the next steps after that?
Well, first of all, the procedure, basically the sort of timing of it has some to do with what you were talking about, this minor and major, or big and small. So that STEMI that we were talking about is something where basically as the healthcare team, we drop everything we're doing. Typically, that's the most important patient that the emergency room will then focus on for the next 10 minutes. interventional cardiologists will come in from home. A cath lab is where we do the procedure. The cath lab team will come in from home if it's the middle of the night, or if it's during the day, they're already there. But we try to get that artery open within 90 minutes of the patient coming in through the door. We call it door to balloon time.
That's very fast.
Yeah, and that includes all of those steps.
Yes.
Being seen initially by someone in triage, and then getting an EKG, being seen by the nurse, the doctor, and then activating this system.
Mm-hmm.
And so that's the goal, and that's a nationwide goal. Now, the other type, if you're not actively having chest pain, if there's, we don't know yet, but if there's a 90% blockage, say a little bit of blood flow getting through, and you're not having active chest pain, then we put you in plan for a procedure, which could be done sometime, generally in the next 24 hours or so. And we put you on some blood thinners to kind of keep things open as much as possible. And then you were asking about afterwards. So basically we go in, put in the stent. Usually it's a stent. Sometimes, occasionally, somebody may require bypass surgery, but most of the time for a heart attack, we do stents. And going through either the wrist or through the leg artery, and then are able to place this. And afterwards, usually the recovery is very good from the procedure because it's a relatively minimally invasive procedure. From the perspective of having a heart attack, we usually keep people in the hospital about 2 to 3 days, mostly for monitoring and a little bit more testing and understanding a little more about their heart, and then hopefully home after that. And then beyond that, of course, there's outpatient, definitely more follow-up. You pretty much need to see a cardiologist regularly for
a while,
forever, or as long as you would like to, I guess.
Yeah.
But and then there's something also called cardiac rehab, which can be very helpful, which is an exercise program that helps people kind of get over the heart attack, get back into exercise, and it's medically monitored.
That's great. So there's obviously different pathways depending on the patient condition, whether it be quote unquote mini or major heart attack, it'll be a different pathway and different sort of recovery. So I'm glad you shared both aspects of, which way you could go and what does that recovery look like for a quote unquote major heart attack.
So Dr. Ghosh, you've talked a little bit about prevention and, how the atherosclerosis kind of builds up over time. It's a continuous process. When should someone start thinking about their heart health?
It really starts with healthy living choices and eating choices and exercise, all of that, which really is in childhood. I don't know that there's an actual age, but I do think any adult person who wants to start thinking about, how to maintain a healthy lifestyle. And part of that may be being evaluated by a cardiologist or maybe just a primary care doctor. So I don't think it's even out of the question for someone in their 20s. And certainly, atherosclerosis is generally silent. It doesn't give you symptoms until you have severe blockages. At least 70% blockage, we think, is what causes symptoms. And so, the steps leading up to atherosclerosis are having high cholesterol, certainly having diabetes, being overweight, and certain genetic factors. I mean, there are many factors, high blood pressure. So
there may be something that could kind of indicate that you might need a little extra care for your heart.
Yeah, and I think a lot of those things are also silent, right? Yeah, having high cholesterol or diabetes or high blood pressure, you may not know those things either unless you go get checked out.
Which underscores the importance of continuing to get your regular checkups from your primary care provider.
Yeah. There are some tests that theoretically can be done to kind of help otherwise asymptomatic, meaning having no chest pain or shortness of breath or anything like that, but taking a look to see if there's something that they should be being proactive about. Probably the one that comes most to mind is what's called the calcium score. This is actually a CAT scan that essentially just looks at the area of your heart where your coronary arteries are to see if there's any evidence of calcified plaque, which is basically on a CT scan, on a CAT scan, looks bright like a bone because it has calcium in it. And so that we can get a score, and that score could be 0, which is great news, or it can be anything from 0 on up. And so sometimes in younger people we'll use that because it helps to risk stratify. That doesn't necessarily mean that they have a severe blockage. It just means there's plaque starting to build up. And it's an indication that maybe we should take your cholesterol and be a little more aggressive. Maybe we should look more aggressively for, or more frequently for, diabetes. Maybe we should think about whether you want to take an aspirin just to help as a preventative measure. These are all kind of considerations if you have a positive calcium score.
Okay. Is that recommended for people that meet certain criteria, or could that be open to?
I think it could really be, frankly, it could be done for anyone. It is frequently used in the position where, cholesterol management has been a very ever-changing process for the last number of decades. The goals have not been the same. At one point, we aimed for an LDL of 160, then we said 130. Then it was more like, well, maybe actually shoot for 100. And then, hey, actually, if you have coronary disease or diabetes, we shoot for 70. So you can see how wide this range is and what's the right and wrong answer. And so sometimes you'll get someone who doesn't have any symptoms, feels well. Maybe they have a cholesterol of 130, LDL of 130, and they're perhaps not too interested to be on a daily medication for the rest of their life. Maybe they're 35 years old, say. So here's a good place where we can potentially use, there are some risk calculators that we can use to try to determine what's your risk. And then there's also this calcium score where you can say, okay, the same 35-year-old with the same LDL, but one of them has a calcium score of 0, another has a calcium score of 50, and then another has a calcium score of 1,000. We know generally from studies that the person with the 1,000 is a little more likely to have a heart attack or some sort of progression of coronary disease going forward. And the person of 50 is going to be more likely the person of 0. So we can kind of use that and say, well, now I might recommend this person to be aggressive about exercise and diet. This person may be a little more, aggressive, and this person maybe should start taking a medication because it's starting to build up a lot more aggressively.
So it's actually getting to the point where you can be a little more personalized and unique in the approach for each individual person. It's not a one size fits all.
Yeah, I do think so.
And then you talked about a little bit of the risk factors. If I had a family history of heart attacks or there's some other cardiac history, is it kind of guaranteed that I would have some of those concerns as well, or I would have a cardiac issue going forward? What are some of the things that I should look forward to?
Yeah, I mean, we definitely utilize the family history to basically another feeder into the kind of equation or the model that we use to try to say, is this person higher or lower likelihood of having something? It's never a one-to-one correlation. Obviously, when somebody has a heart attack, if they are under the age of 50, actually we use 50 for men and usually 60 for women, we consider that kind of premature, meaning it's early in their life to have had a heart attack, okay? So if you have a family member who had a heart attack, below the age of 50, then we consider that to be a more strong family history. Versus if, and we get this a lot, right? People say, do you have any family history? And someone says, yes, my grandfather died of a heart attack when he was 92. It's not irrelevant. However, if you had a grandfather who died of a heart attack at 42, that's a very different condition because you've now had 92 years of lifestyle and environmental factors that are affecting your likelihood of having a heart attack.
It's still, again, that more personalization of somebody's risk factors and life. As a cardiologist, and as we, think about heart care and into the future, what excites you about what you do and what may be coming in the future?
Lots of things, I think. I would say, we're definitely moving very aggressively into the space of minimally invasive therapies. Balloon angioplasty and stents have been around for a very long time now. And a lot of heart attacks, as we were talking about, are treated that way. We're also treating a lot of valve heart disease, valve-related heart disease as well with, open heart surgery, of course, and that's always going to be there and has been there for a long time, but a lot of minimally invasive therapies as well for that. Probably the biggest example right now is transcatheter aortic valve replacement, which I mentioned earlier. Aortic valves can start to get stiffer and not open well. It's usually a condition of patients aged 60 or mostly like 70 onwards. And as that starts to happen, sometimes you need to replace the valve. And we can do that now with a catheter-based procedure, basically where we deliver a large stent that has a functioning valve on the inside through a big artery through the leg. And it's a quick, less than an hour usually procedure, and people stay in the hospital one night. So it's a big dramatic change in how somebody might get their valve replaced.
Okay.
So we're not like going back to like open the chest and replace valves that way anymore.
Well, we definitely are still. So
That's still an option.
I want to be clear about that, because as with anything, using more finesse and trying to snake through arteries and deliver a valve, you have to have the right anatomy for it. You have to be the right patient for it in general. And, there are also considerations of your age. And, sometimes we may think about a younger patient and say we should do a full open heart operation where we replace the valve. Certain types of aortic valves, for instance, would maybe be better for surgery. So we actually work we call it a heart team. And so we have meetings every single week where we meet with a heart surgeon, interventional cardiologists, and sometimes imaging experts if needed. And we go through and discuss cases and try to come up with the best plan.
That's great. Staying up to date and making sure that the evidence is really guiding the treatment that you're going towards.
All right. Well, thank you for coming today. We really appreciate all of this wonderful information you've given our listeners. Anything that you want to add? Any tips or anything like that for people to take better care of their hearts?
I guess awareness is probably the way to put it. We live in a world of tech. I think these days that has helped to increase awareness. If you use it in those tools, just like anything else, use the tools in the right way, can really be helpful. So I think a lot of the watches and heart rate data and steps and, can be a lot of good self-feedback for trying to remain active, trying to make goals for yourself every day, or, being aware of if something seems to be off, is something happening with your heart rate? Are you going into an irregular heart rhythm? Those types of things are very helpful. And obviously, I'm sure everyone, talks about diet and exercise, and those are always going to be the pillars of maintaining heart health.
I like that, though, what you said, just aware and use technology or other things to just kind of help you along too. You don't have to do it all on your own.
And people could actually measure 10,000 steps now. They're like, I'm going to do my 10,000 steps today.
Maybe it just makes it a little easier to achieve any goals that you set if you've got a little something to help you track it.
I think it's a great tool, because even if you see a cardiologist as regular as you need to, like 6 months or something, and they say, hey, please do, exercise, that's very different than something on your wrist telling you
every day
haven't stood up in the last 55 minutes.
My watch does that. Definitely gives you some perspective.
It does.
It's very helpful, actually, to keep active, physically and mentally both. And I think those tools are here to stay. Not just get better.
Well, speaking of awareness, Adventist Healthcare offers a free and fast health risk assessment online. So it's a simple little quiz that you put in some information, and it helps you become more aware about your risks and your risk factors for heart disease. So we have that resource available that we'll put in today's show notes too.
That's great.
Well, thank you, Dr. Ghosh. We appreciate your time today.
Yeah.
We hope you'll come back again.
Absolutely.
Thank you. To find more information about Dr. Ghosh, visit AdventistHealthcare.com. You can also go there as well and learn more about the Adventist Healthcare Heart and Vascular Institute. And as always, we'd love to hear from our listeners. You can let us know if you like the podcast by leaving a review, or you can email podcast@AdventistHealthcare.com. Let us know about healthcare topics you want to know more about. Don't forget to subscribe to get all our new episodes. Thank you to our listeners, and be well.